So for the management of chronic kidney disease, you need to go back to for the management of renal failure, we start with the management of acute kidney injury, where you need to go back to SchrDbb algorithm. To manage the disease, which is the renal failure, generally it is a renal replacement therapy. When there is renal failure, the management of the renal failure is renal replacement therapy, provided there are indications for renal replacement therapy. And now we need to see now the indications of renal replacement therapy. The indications are the R is for anuria. If you have anuria for more than 12 hours, it's an indication for a renal it's an indication for dialysis or renal replacement therapy. The next one, we have after anuria, we have a case of acidosis. Acidosis is when a pH is going to be less than 7.2. Then the next one is air. Air is electrolyte imbalance. Air is electrolyte imbalance, particularly when the potassium ion is greater than 6.5 milliequivalent per liter. Then in this case where there is air, potassium ion greater than 6.5 milliequivalent, it is when there is renal failure. I hope that all this is when there is renal failure. You have already established that there is renal failure. So for dialysis to be done, you must first establish that there is renal failure, and then you have this indication. E is intoxication, provided that there is an overdose of any medicine, or an overdose of a product like alcohol. You should give him dialysis. O is overload, particularly in the case of a pulmonary edema. You have to give him dialysis. And O is in the case of a uremic syndrome or a uremic encephalopathy, particularly uremic encephalopathy like a convulsion or a coma. You have to give him dialysis. And I've said that this uremic syndrome usually occur when the urea is greater than 100 milligram per deciliter. So those are the different elements that you have to note before you dialyze the patient. So for the diagnosis for the disease here, the management of the disease generally is renal replacement therapy, and you have the indication for that. Now for the management of generally, you need to know that the simple way to manage for acute kidney injury, if you don't have dialysis, you have to first manage for the complications. And we have already seen the different complications that we have in acute kidney injury. Now, the first complication that we had is fluid overload. When you have fluid overload, like pulmonary edema, the best thing to give is just to give diuretics. Is it clear? You give diuretics while controlling the ions. Is it clear? You have to give diuretics to the patient. Now, the next thing is when you have acidosis, the management of pulmonary edema, you have to give diuretics. Is it clear? Give diuretics to the patient such that the urine output should be more than the urine input. Now, the next thing is acidosis. If there is acidosis, you have to give sodium hydrogen carbonate to the patient. That's bicarbonate. Is it clear? To the patient. Is it clear? Now, when the patient has hyperkalemia, is it clear? There is a protocol. Generally, the first line in the management of hyperkalemia is to give cell membrane stabilizers. Cell membrane stabilizers. Example of cell membrane stabilizers, we have calcium gluconate. Is it clear? You give cell membrane stabilizer. Example is calcium gluconate. Now, after giving it and it's failing, you have now to use shifters. Is it clear? You give shifters like a beta agonist. Beta agonist like salmeterol. Salmeterol is a long-acting beta agonist. Or you give a patient insulin with glucose which is a shifter in order to prevent insulin with glucose in order to prevent hypoglycemia. Is it clear? So those are shifters. They're going to shift the potassium ion into the cells. Is it clear? Now, after the second line has failed, we go down to the third line, which is still diuretics. and particularly it is loop diuretics, is it clear? And all the diuretics except from anti-aldosterone like spironolactone, which is a potassium ion sparing diuretic. So in this case, you give the loop diuretics, and the loop diuretics like furosemide is going to cause the loss of the iron. And then lastly after the loop diuretics, now you have the fourth one, the fourth element after the loop diuretics. After the loop diuretic, the fourth element that you have to give now is renal, is dialysis, and dialysis is only given provided that there is failure to the management above, or there is it is seen that the patient has renal failure. So those are the different elements that you have to put. Now the next complication that we had in the patient was so that is for acute kidney injury. In a case where the patient has a uremic syndrome in acute kidney injury, you need to know the mechanism of uremic syndrome, or uremic encephalopathy. Generally, if somebody has uremic syndrome, the management is renal replacement therapy. But if a patient has uremic encephalopathy and you don't have renal replacement therapy directly, what you have to do is to place the patient on monitor. You place the patient on monitor because the mechanism of uremic syndrome, of uremic encephalopathy, is cerebral edema. Let us explain how this occurs. You need to know that there are three major cellular spaces inside the body, as I'm always explaining. Intracellular space, intercellular fluid, we have the interstitial fluid, and we have the intravascular compartment. In a case of uremia, you need to know that what. So let's say that normally here is potassium ion, here is sodium ion, and there is chloride ion, and here is sodium ion, chloride ion. Is it clear? Now you need to know that urea, which is accumulating in a case of renal failure, is going to penetrate more in the intracellular space. Is it clear? So it's going to increase